Hello and welcome to the second installment of Better Understanding Women's Health. Today's presentation is Contraception Misconceptions. My name is Grace Burnt and I am the Marketing Communication Specialist at McLaren Care Region. During today's broadcast, as questions come up, please feel free to comment them in the comment section below and we'll make sure that they get addressed at the end of the presentation. Today, I have the honor of introducing Dr. Jessica Gibson. She is a family practice physician at McLaren Care Region.
Thank you so much, Grace. Happy to be back. As Grace mentioned, our title for today is Contraception Misconceptions. Please feel free to leave any questions. I'd be happy to answer them at the end. So my objectives for you today are very similar to last time if you tuned in that I want you to be able to have an informed discussion with your provider regarding birth control options and what might be appropriate for you, especially if you're unhappy with your current method. I'm going to start by going through the various types of birth control, and then we will finish up with some of the common misconceptions or things I hear in the office. So I might as well start with, if you're not interested in contraception, maybe you're trying to have a baby, you don't believe in birth control, whatever the case may be, I think it's very important to mention that if you are not taking methods to prevent pregnancy, we should probably be treating it as though you could become pregnant. So we want to make sure that if you were to become pregnant, we would be providing the safest environment for a baby. So make sure that if you haven't already, you've started prenatal vitamins. I honestly recommend these for all ladies who are premenopausal because they just make you feel good. Stop any unhealthy habits that you may have, such as smoking, drinking, using any sort of drugs, including marijuana. Get at least 30 minutes of exercise 3 to 5 times a week and maintaining a healthy BMI. I think this can go for all of us, to be perfectly honest. And then talk to your provider about any medications that you may be on that, if you should become pregnant, might be harmful to baby. And without further ado, I kind of structured the birth control options here from least effective to most effective, but I do want to be clear that statistically speaking, most of these methods are pretty comparable as long as they are being used correctly. So to start, we'll discuss barrier methods. These include condoms and women's diaphragms. Essentially, they create, as it says in the title, a barrier between the sperm and the egg. So in theory, sperm does not meet egg. Of course, both can fail. Condoms, of course, most of us are aware, are available over the counter. Biggest thing there, of course, is that you kind of have to plan for intercourse because there is that extra component of being prepared. I do want to point out it is the only contraception method that we will be talking about that also prevents any sort of infections. So it's often common to use this with other forms of birth control as well, purely for that benefit. Women's diaphragms, they do need to be prescribed by a provider because you have to be measured. Every woman has different anatomy, as I'm sure you can imagine, and we need to make sure that we are giving you the device that fits the most appropriate. There are several different types of devices out there as well. These are most effective when they're also used with some sort of spermicidal agent, which you can typically get over the counter. These are foams, gels, etc., that essentially kill off the sperm. I will say of all of the forms of birth control, this is probably the least used one because most women express that they are uncomfortable, but if it's something you've been using, a lot of people really do like them. The other thing to note is most family physicians or primary care providers do not have the appropriate training to measure for these. So this is typically something that you would have to see a gynecologist for. Next, oral contraceptives, which is probably one of the more common options just because they're very easily accessible and somewhat easy to use. The most important things to know is how it works. So most oral contraceptives contain both estrogen and progestin, which are natural hormones that our body has, and they essentially help to regulate our cycles. The goal being that they prevent ovulation. There is a progestin-only pill out there. This is sometimes referred to as the mini pill. The advantage here is that we lose out on the estrogen. So if for some reason you can't have estrogen, there is certainly that benefit. We often use this for breastfeeding women because estrogen can dry up milk supply. The other thing to note with the progestin only, however, is that that old kind of misconception that it has to be taken at the exact same time every day. The progestin-only pill really does need to. If you're even 3 hours off, it essentially loses its efficacy. We don't see that with the regular oral contraceptives. Those just really need to be taken daily, roughly at the same time if you can. Oftentimes you can skip periods with oral contraceptives, but that's something you should absolutely talk to your provider about. Next is the patch. The only branded patch that I'm aware of that is still out there is called Xulane. It's very similar to the oral contraceptives in that they contain estrogen and progestin. So you're going to get that same sort of systemic effect. Essentially, you apply a patch, you wear it for a week, you swap it out for the next one. After 3, you leave one off and you have your period. Again, this is another option that you could potentially miss periods with. So, talk to your provider if that's something you're interested in doing. This should typically not be prescribed for anyone with a BMI over 30. The reason being there is because fat does prevent the absorption of the hormones. So if, you're a little fluffier, we can't promise how much of the hormones are being absorbed. And therefore, we don't want an unwanted pregnancy for you if that is the purpose of the patch. I will say I've used it for patients with a BMI over 30 when we are using it for other reasons, such as period regulation, and it has worked well. But they've typically used another option for contraception. Next are the vaginal rings. There are 2 out there that I'm aware of. Although the Anovera has recently come out in the last few months, so I wouldn't be surprised if there's more on the market at this point. NuvaRing is the one that's been around for a while. Most people are more familiar with. They are similar to the oral contraceptives, again, in that they contain the estrogen and progestin, so you get that systemic component. Essentially, you insert one of these devices for 3 weeks. It kind of hangs out around the cervix, stays in there pretty well. You don't really have to worry about it falling out, but certainly if it does, you rinse it off, put it back in. You remove it to have your cycle and then reinsert the next one. For the NuvaRing, you do have to use a new ring monthly. The Anovera, each ring lasts 13 cycles, so essentially one device will last you a full year for birth control. It's currently being marketed as if you are interested in an IUD but do not want an actual implantable device. Again, can skip cycles, talk to your provider. This is one of those, I think, most women either love it or hate it. There's really not an in-between, but I do have a lot of patients that really like this option. So who should not use the things we've already talked about? The oral contraceptives, the patches, and the rings. The big thing to know here is that estrogen does increase your risk of strokes, blood clots, and heart attacks. So anybody who already has risk factors for these things should probably either not use these items and or should really have a risk and benefit discussion with their provider. This would include women over the age of 35 who smoke. The more birthdays we have and the more cigarettes we've smoked in our lifetime are really the risk factors there. Women with uncontrolled blood pressure despite medication use or who may be on several medications. If you have any migraines with aura, certain types of breast cancer are sensitive to estrogen, so it should probably be used with caution. And then liver disease because it already is affecting your blood clotting cascade. So again, it's not to say that these items should not be used at all. It's just, important to have that discussion with your provider. Next, we'll get into the longer term options. So the first thing to discuss would be Depo-Provera. This is more commonly known as the shot. So it's progestin only. You lose out on the estrogen. Advantage there is that estrogen does tend to cause a lot of the side effects we hear about with birth control, such as mood swings, acne, things of that nature. So we do tend to lose that with the progestin-only options. Still works to ultimately prevent ovulation. Each shot lasts 3 months, roughly 12 to 13 weeks. It is very important that you get the shot consistently that 12 to 13 weeks because as soon as you're out of that window, you can become pregnant. Most women with the shot have decreased cycles. Some go on to not have, periods at all. So a lot of women really do like this option. Studies do suggest bone density issues if it's being used over time. So actually, if you read the package insert, it does state that Depo-Provera should not be used for more than 2 years at a time without a break. Most providers will tell you that we still prescribe it beyond the 2 years. it's just, again, a risk-benefit situation. I typically suggest for my women, if they're going to be using Depo-Provera, to take calcium and vitamin D supplementation to kind of prevent that. Next are the implantable devices. So the only one that is still out there for this is the Nexplanon. It's a small device about the size of a matchstick. I do have one here with me. I'll show you in a minute. It goes in the arm. You can feel it. It's an easy in-office procedure. For most people, it takes about 5 to 10 minutes to insert, maybe even less, honestly. It's good for 3 years, but of course, we can take it out at any time if you should choose to become pregnant, or of course, if you have any trouble with it. It is progestin only, so again, it's kind of similar to the Depo-Provera in terms of how it works, but we have not seen the bone density issues with this. Most women, again, have significant decrease or complete stop of bleeding with the Nexplanon, so it is very favored in that. And again, without the estrogen, you tend to not get the mood swings, the acne, or any of the other side effects that tend to go along with oral contraceptives. So again, it's inserted just kind of, sorry, getting the camera here, in the lateral arm. And I know I said it's about the size of a matchstick. If you can compare to my thumb, maybe, there's about the size of it there. So a pretty small device, you can feel it, so you'll always know if anything should happen to it. Next, we'll talk about the intrauterine devices, or the IUDs. This is a T-shaped device that is inserted into the uterus. There are a couple different flavors of these, so to speak. There's the hormonal and the non-hormonal. With the hormonal ones, you do get that progestin, same as the previous options we've talked about. These are the more commonly known ones as Liletta, Skyla, Kylena, Mirena. There's probably going to be more coming out. These are very popular. Depending on which one you choose, it's good for anywhere from 3 to 6 years. I will throw a caveat on that 6 years. There's a lot of studies being done right now to see if they can last potentially even longer than that. Advantage of these is the hormones are localized to the GYN tract, so you don't have to worry about any sort of systemic side effects with these. 90% of women have no periods with these, and if you are one of the unfortunate ones that does have periods, it tends to be very light, spotty, certainly, not as heavy as what your historic periods may have been. The other option is the non-hormonal, which a lot of women like for that purpose. This is the copper one, or the Paragard is the brand name. Essentially, it creates inflammation within the uterus, which interferes with sperm transport. It is good for 10 years, so a lot of women like that aspect too. But again, it is non-hormonal, so there's absolutely no change to periods whatsoever. A lot of women do report an increased or heavier period in the first several months of using this, and as well as a little bit more cramping. But if you can hang out with it for 6 months or so, typically that does resolve. Just to, again, give you a size comparison, I'll try to do better this time. This is about the size of an IUD, and there's comparison to my thumb. So they're pretty small device. The strings, there are strings that hang out of the cervix. This is kind of the texture of fishing line, but as they're in there longer, the cervical mucus does soften them up and they wrap right around the cervix. So typically your partner is not going to feel them, but certainly if they do, we can always shorten the strings. I do want to mention that for both Nexplanons as well as IUDs, you do have to have special training to insert these. So not just any provider can do it. If you're tuning in from the Carroll region, myself as well as Heather Friars, my nurse practitioner in my office, both do the Nexplanon insertions. And then the IUDs, I believe I'm the only one in town that does, but I can't be 100% sure there. But of course, any gynecologist would be able to. So moving on to misconceptions. So birth control will make me gain weight. I get this one all the time. It is false mostly. So studies have shown that the only form of birth control that actually does cause weight gain is the Depo-Provera, that shot, which on average for women causes 5 to 6 pounds of weight gain. So again, for my patients who are a little fluffier, I tend to not recommend this unless this is really what they have their heart set on. Some of the other birth controls, such as the Mirena, I believe Nexplanon does as well, do list weight gain as a possible side effect, but that's typically due to bloating. So again, if you can wait that cycle or two, that does typically resolve. So if you're blaming your weight gain on your birth control, chances are there might be something else going on. So bring up that concern with your provider. Next, I saw on Facebook that next one on can travel. Again, false mostly. As I kind of alluded to, Nexplanon does require all providers to be specially certified to insert this device. This is a little bit more intense than any of the other trainings that a provider would go through. You have to go to a special class, there's retrainings and so forth. And in order to even order this device, you have to prove that you've been to one of these classes and that you're a registered provider. So this is not something that just anybody can do. If it is placed correctly, migration of over 2 centimeters, which is truly a very small amount, is very, very, very rare. Of course, there are going to be case studies, and if you go down the Dr. Google pathways, I'm sure you'll find big, scary things. But again, it's very, very uncommon. If for some reason you ever can't feel it, let your provider know. I will say typically that's related to scar tissue building up, and it's just caused it to go a little bit deeper. So just a quick ultrasound will verify it's in the right place, and that will make everybody sleep better. Same sort of idea. I saw on Facebook, IUDs can perforate my uterus. False mostly. Again, this is very, very rare. If you look up all the case studies in which this has happened, most of the cases are in women who are breastfeeding, who had the device placed immediately after birth, so before they even leave the labor and delivery unit. The suspected reason for this is because the uterus is already very thin and weak due to the stretch and, of course, having a baby. So, if that's already kind of weak, there's always that possibility of puncturing it. Again, if it's inserted by a trained provider, the chance is almost negligible. In fact, I tried to find a percentage for this talk to bring that up to you, and they won't even give a percentage. It's less than a 0.01% chance. So we do encourage all of our patients to do a monthly string check. And if for some reason you can't feel it, let your provider know. It's as simple as an ultrasound if needed, just to verify that it is still in fact in the correct place. Birth control causes cancer. So I kind of alluded to this earlier. Some breast cancers are sensitive to estrogen. So if you are using an option that has estrogen, such as the oral contraceptives, there could be a slight increase in their risk. All that to say, if your breasts already have that propensity, you probably do already have that risk. This just might bring it on a little bit sooner. So this does carry a warning within, especially the oral contraceptives. There's also a note that studies have indicated a slightly higher chance of getting cervical cancer. The thought behind this is most women who use birth control tend to not use condoms. So you're getting more exposure to HPV, which is that virus we know causes cervical cancer. So if you are using condoms in addition to the oral contraceptives, this may in fact kind of equal and balance itself out. But the important thing to know is that it actually does lower your risk for endometrial, colorectal, and ovarian cancers. So again, kind of sort of true, but also can protect against some other options. Birth control damages fertility. Absolutely 110% false. Depending on the choice of birth control, I will say it may take longer for your cycles to regulate to allow a pregnancy. Oral contraceptives tend to be the one option that takes a little bit longer, but most women become pregnant within a year of stopping their birth control, which is comparable to women who are not taking birth control when they actively start trying. So it's really just a matter of when your periods regulate themselves again. Older people do not need birth control. Also kind of sort of false. If you are still having regular periods, you can in fact get pregnant. Fertility for men and women does decrease as we age, but pregnancy is still possible as long as you are having periods. So if you haven't gone through menopause and you've not had any surgical procedure to prevent pregnancy, it's definitely worth considering. When I say surgical procedure, of course, I mean either a tubal ligation or your partner having a mastectomy. So that being said, I will open things up for questions if there happens to be any out there.
Questions from a couple listeners here. Becky asks, what is the most common form of birth control?
So I would say probably the most common form of birth control that I tend to see people asking for is just the oral contraceptives because they've been around for so long that people are a little more familiar with them. I will say I'm getting a lot more patients coming in who are requesting the IUDs just because they're so easy. They last so long. You don't have to remember to take a pill. But I really think it's kind of, certainly patient preference. The health department tends to do a lot of the Depo-Provera injections. I don't have too many people in my office that actually request those, though.
Thank you. And we have one more question from Laura. Since we're discussing misconceptions, I've heard a lot of ladies believe that if you are breastfeeding, then you can't get pregnant. Is that true?
No, it is not. So, excuse me. If you are breastfeeding, the chances of you ovulating are certainly a lot lower. Most women who are breastfeeding tend to not ovulate or have a regular menstrual cycle until about 6 months in. If you are one of those lucky ladies that happens to have a menstrual cycle earlier in the game, meaning in that 1 to 2 month mark, get pregnant right away and never have had a normal period to begin with. So if you are breastfeeding, we still do recommend for some sort of birth control option. Again, the mini pill is very commonly used. But again, if you're interested in getting any of those implantable devices, that certainly works just as well. We try to avoid, as I mentioned, the IUDs on the labor and delivery floor, but I've definitely worked with gynecologists and obstetricians who will actually insert the Nexplanon, that arm device, on the L&D floor, so you're protected immediately.
Thank you, Dr. Gibson. That's all the questions we have for today. Thank you again for sharing your time and knowledge with us. And as a reminder to everyone listening, we do have one more presentation that's coming up on July 13th. And Dr. Gibson will be back on Facebook Live discussing ways to manage menopause. Thank you again, everyone, and have a great night.